It is completely invisible to you right now, but at this exact second, your body is executing one of the most incredibly complex, high-stakes balancing acts in the known universe.
Oh, absolutely.
I mean, you just took a breath. And then another one. Your diaphragm dropped. It created this negative pressure vacuum in your chest cavity, and air just rushed in from the atmosphere to fill the void.
Right, it's so automatic we completely ignore it.
Exactly. Right up until the moment it stops working perfectly.
Yeah, it really is the ultimate invisible machinery because every single cell in your body is just, screaming for oxygen to produce energy.
Right.
And simultaneously, they're producing carbon dioxide as this toxic waste product. So the respiratory system is literally the only thing standing between cellular life and immediate suffocation.
Which is terrifying when you put it like that.
It is. And when we look at respiratory health, we are really looking at a masterclass in cause and effect. I mean, a tiny structural failure in a microscopic air sac, or say the sudden arrival of a viral invader.
It doesn't just stay localized.
Exactly. It triggers this intricate cascading domino effect that can essentially crash the entire system.
Okay, so let's unpack this. Our mission for you today is simple, but it's huge. Whether you are just insanely curious about the biology keeping you alive, or maybe you're trying to make sense of a relative's recent diagnosis.
Or prepping for a major clinical exam.
Yes, exactly. We're going to dive into the absolute high-yield mechanics of the human airway. We're drawing on these fantastic nursing care modules covering respiratory health problems from Sheridan College.
They're excellent sources.
They really are. And we're stripping away the rote memorization here. We're looking at the foundational clinical presentations of respiratory failure to understand not just what breaks down, but the precise cellular and mechanical reasons why it breaks down.
And, taking that approach, focusing on the why rather than just memorizing a dry list of symptoms, it changes everything.
Totally.
Because if you understand the first fallen domino, the rest of the disease process just makes logical sense.
Yeah.
You don't have to guess why a patient looks a certain way.
You can deduce it purely from the mechanics.
Precisely.
So let's start at the perimeter. Before we get anywhere near the delicate tissues of the lungs, the body has this massive multi-tiered security apparatus to deal with the outside world.
Right. Because we aren't just inhaling pure, clean oxygen.
Not at all. Every breath is just full of dust, pollution, pollen, bacteria, viruses.
The air we breathe is incredibly dirty. And honestly, it is usually the wrong temperature and humidity for our internal organs anyway.
So the first line of defense is filtration and conditioning, starting right at the nose.
Yep. The nasal cavity isn't just a tube, It's this labyrinth of bony structures called turbinates.
Which force the air to swirl in this crazy turbulent pattern.
Exactly. And as the air violently swirls around, heavy particles of dust and debris are literally thrown outward by centrifugal force. They just slam into the walls of the nasal cavity.
And those walls are coated in mucus, so the trash just sticks to the walls, like flypaper.
Flypaper is the perfect analogy. But it's not enough to just trap the dirt. You have to actually remove it.
Right.
So beneath that sticky layer of mucus are millions of microscopic hair-like structures called cilia.
I've always pictured cilia like a field of wheat blowing in the wind.
That is a great visualization, provided the wind is only blowing in one specific direction.
Right, they all have to sweep together.
Exactly. These cilia beat in a synchronized upward wave, typically around 1,000 times a minute. We call it the mucociliary escalator.
The mucociliary escalator. I love that term.
It's very descriptive because deep in your lungs, the cilia are constantly sweeping that contaminated mucus up the bronchial tree into the trachea and eventually to the back of the throat.
Where it is either swallowed into the highly acidic stomach and destroyed or just coughed out.
Exactly.
And if something highly irritating sneaks past that escalator, the body's reflex is to just shut the door, right? Reflex bronchoconstriction.
Yeah, the smooth muscles around the airways just clamp down to prevent the irritant from getting deeper.
And then the cough reflex explosively forces it back out. But, okay, let's say something incredibly tiny. A microscopic piece of silica dust or a highly adapted virus manages to bypass the turbinates, dodge the flypaper mucus, survive the escalator, and get all the way down into the deepest, most delicate part of the lungs.
The alveoli.
Yes, the actual air sacs where gas exchange happens. What is the final line of defense down there?
Well, at that level, you cannot rely on mucus or cilia. Those structures are just too thick.
Because if you put a layer of thick mucus inside the alveoli, Oxygen wouldn't be able to pass through it into the blood.
Precisely. The air sacs have to be pristine and paper thin. So instead of a physical barrier, the body uses a biological one, alveolar macrophages.
Oh, the cellular Pac-Men.
Yes, there are these highly mobile white blood cells that patrol the deepest vaults of the lungs. They literally crawl along the surface of the alveoli, just seeking out foreign debris.
And when they find a piece of dust or a bacteria,
They physically surround it. They engulf it in a process called phagocytosis, internalize it into a microscopic bubble within their own cellular body, and then flood that bubble with acid and digestive enzymes to dissolve the threat.
I mean, it sounds like an impenetrable fortress.
It's remarkably efficient.
But nothing in biology lasts forever. And I want to talk about how this fortress degrades over time, because the clinical literature puts a massive emphasis on age-related considerations in respiratory health.
They absolutely do. It's a huge focus in geriatric nursing.
Right, and they divide this degradation into 3 distinct categories: structural changes, defense mechanism changes, and respiratory control changes.
Let's start with the structure, yeah.
Yeah, the sources note that as we age, lungs lose their elastic recoil and chest wall compliance decreases. Now, compliance is one of those medical words that I think tricks people up.
It does sound a bit counterintuitive.
Right, because in physics, if something is highly compliant, it stretches easily. So decreased chest wall compliance means the rib cage is getting stiff.
Exactly. The cartilage connecting the ribs to the sternum actually calcifies and stiffens over decades.
Wow.
And at the same time, the muscles between the ribs, the intercostal muscles, they lose mass. So the physical cage surrounding the lungs becomes much harder to pull open.
I'm visualizing a bellows, like you'd use to stoke a fire.
Oh, that's a good one.
When the bellows is brand new, the leather is soft, and you can easily pull the handles apart to suck air in. That's a highly compliant chest wall. But leaving it out in the sun for 50 years makes the leather crack and turn rigid.
So pulling those handles apart now requires serious mechanical effort.
Exactly. But you also mentioned the loss of elastic recoil in the lungs themselves, which seems equally critical.
Oh, it's vital. The tissue of the lungs is packed with a protein called elastin. When you breathe in, you stretch that elastin.
Okay.
And when you relax, the elastin naturally snaps back to its original shape, which forcefully pushes the stale air out.
Like a heavy industrial self-closing security door. You exert force to push it open and get air in, but you don't have to use energy to close it. The heavy spring naturally pulls it shut to push the air out.
Exactly right. But over a lifetime of breathing and exposure to even mild environmental oxidants, that elastin protein breaks down.
So the springs in your security door get rusty and lose their tension.
Yes. So an older adult isn't just fighting a stiff chest wall to get air in. They actually have to start using muscular effort to actively push the air out because the lungs won't snap back on their own.
Which means the baseline energy cost of just sitting in a chair and breathing is significantly higher for an older person.
It creates a really dangerous vulnerability. When a healthy older adult is resting, they compensate for this mechanical stiffness perfectly well.
Sure.
But the moment a respiratory challenge arises, say they catch a mild pneumonia, they simply do not have the physiological reserves to fight it.
Because their breathing muscles are already working near capacity just to maintain baseline gas exchange?
Precisely. This is why a respiratory infection that causes a mild annoyance in a 20-year-old can cause rapid, catastrophic decompensation in an 80-year-old.
And it isn't just the mechanics failing, right? The internal security staff is falling asleep at the wheel.
The defenses absolutely slow down.
Yeah, the text highlights a decrease in alveolar macrophage function, a drop in cell-mediated immunity, fewer specific antibodies being produced, and a slower, weaker beating of the cilia.
The bouncers at the door are lazy, and the roving Pac-Man guards are lethargic.
Exactly. But the point that really made me pause is the change in respiratory control. The sources say aging causes a decreased response to hypoxemia, which is low blood oxygen, and hypercapnia, high carbon dioxide.
Yes, that is a huge clinical pearl.
So wait, does that imply what I think it implies? If our internal alarms for low oxygen decrease with age, an older person might not actually feel like they are suffocating until they are on the brink of death?
It is one of the most insidious aspects of geriatric respiratory care. Because in a young, healthy system, we have central chemoreceptors in the brainstem and peripheral chemoreceptors in the carotid arteries and aortic arch. They are constantly monitoring the pH, oxygen, and carbon dioxide levels in the blood.
Like internal smoke detectors.
Exactly. And if oxygen drops even slightly, those sensors trigger an immediate aggressive panic response. Your brain initiates a feeling of severe air hunger. Your heart races, you start hyperventilating, you feel extremely anxious.
Your body screams at you to do something to fix the imbalance.
But in older adults, those chemoreceptors become blunted. The neurological alarm bell is muffled.
That is terrifying.
It is. They could be experiencing clinically significant hypoxemia oxygen levels that would have a younger person gasping for air and visibly distressed. And the older adult might just appear slightly confused, or fatigued, or maybe just sleepy.
This is a huge takeaway for anyone listening who acts as a caregiver. You cannot rely on a geriatric patient complaining of shortness of breath.
Absolutely not.
Because by the time they visibly look like they are in respiratory distress or finally complain of air hunger, the situation has likely already degraded into a severe medical emergency.
You have to look for those subtle signs. Unexpected confusion, lethargy, a sudden change in personality.
It might not be dementia acting up. It might be their brain literally starving for oxygen while their blunted alarm system just fails to ring.
It fundamentally changes how healthcare providers assess vulnerability. It demands proactive monitoring rather than reactive treatment.
Okay, with those baseline defenses and aging mechanics established, I want to guide our journey upward to the very first point of entry. The nose.
The gateway to the airway.
Right, because before air even reaches the lungs, it has to navigate the upper airways.
Yeah.
And the clinical modules dedicate a lot of time to what happens when things break down up there. Broadly, they divide these issues into structural or traumatic disorders and inflammatory or infectious issues.
Let's look at the structural side first.
We have deviated septums, where the central cartilage of the nose is deflected to one side, which I assume alters that turbulent airflow we talked about earlier.
It does. We also see blunt force trauma resulting in nasal fractures. And then we have epistaxis.
Epistaxis, which is the clinical term for a nosebleed.
Very common, incredibly common across all age groups, driven by anything from trauma and foreign bodies to the abuse of nasal sprays, street drugs, or even severe allergic rhinitis causing intense local inflammation.
The nursing care interventions for epistaxis in these texts really caught my eye, because they seem to directly contradict a piece of playground medical wisdom that almost everyone grew up with.
Oh, I know exactly what you're going to say.
The sources explicitly instruct the caregiver to keep the client quiet, place them in a sitting position, and have them lean forward.
Yes. Lean forward.
I feel like every kid in a schoolyard was told to tilt their head back and look at the sky during a nosebleed. I'm assuming that playground rumor is completely wrong, but I really want to understand the actual mechanics. Why is leaning forward the medically sound advice here?
Tilting the head back is indeed one of the most persistent and potentially dangerous medical myths out there.
Dangerous, really.
Oh, yeah. To understand why, you have to look at the anatomy. The front part of the nasal septum is highly vascular. It contains this dense network of fragile blood vessels called Kieselbach's plexus.
Yeah.
When those vessels rupture, blood flows rapidly. If you tilt your head back, you are not stopping the bleeding in any way. You are merely changing the direction of the flow due to gravity.
You're just hiding the blood from the outside world.
Exactly. The blood flows backward, down the nasopharynx, and into the back of the throat. This creates two immediate crises. First, blood is highly irritating to the gastric mucosa, the stomach lining.
Oh, I see where this is going.
Yeah. If a patient swallows large amounts of their own blood, it will almost certainly trigger severe nausea and vomiting.
And vomiting is forceful.
Very forceful. It involves massive spikes in intrathoracic and vascular pressure, which will aggressively increase the bleeding in those delicate nasal vessels. You create a vicious cycle.
Okay, so that's crisis number one. What's the second crisis?
Airway compromise. That pooling blood in the back of the throat can easily be inhaled, aspirated straight down the trachea and into the lungs.
Which is a disaster.
Exactly. So by sitting the patient upright and having them lean forward, you use gravity to drain the blood out of the front of the nose. This protects the airway and the stomach.
Makes total sense.
No.
And then once they're leaning forward, the intervention is to apply direct pressure by pinching the entire soft lower portion of the nose against the facial bones for a full 10 to 15 minutes.
Yes. You're manually compressing that vascular plexus against the hard cartilage of the septum. You're essentially acting as a physical tourniquet for the broken vessels.
The text also mentions applying ice compresses to the forehead and having the client suck on ice. The mechanism there is vasoconstriction, right?
That's right. The cold temperature signals the smooth muscles in the walls of the facial blood vessels to clamp down.
Shrinking the pipe diameter to slow the flow of blood, giving the body's natural clotting factors time to patch the hole.
That is the exact mechanism. You reduce the flow, apply pressure, and allow the platelets and fibrin to form a stable plug.
Speaking of platelets and clotting, the sources dive into rhinoplasty next, the surgical reconstruction of the nose.
Which can be for cosmetic reasons or to fix severe airway obstruction from trauma.
Right. And there's a major preoperative nursing instruction highlighted here. Absolutely no aspirin or NSAIDs like ibuprofen for a full 2 weeks prior to the surgery.
That is a critical instruction.
I want to build an analogy for this. Let's think about platelets, the cells that rush to a cut and clump together to form the initial plug-like microscopic Lego bricks.
Okay, I like that.
Normally, when there's an injury, the body sends chemical signals that make these Lego bricks super sticky, allowing them to snap together tightly and seal the leak.
Right, and the chemical signal making them sticky is a compound called thromboxane A2, which the platelets release to call for backup.
Perfect. So taking NSAIDs or aspirin right before a rhinoplasty is like coating all your Lego bricks in heavy industrial grease.
Ooh, yeah.
The Legos still arrive at the scene of the injury, but the chemical signal is blocked. They can't snap together. They just slide right past each other.
That is beautifully explained. The mechanism of NSAIDs is to inhibit the enzymes that ultimately produce that sticky thromboxane A2 signal.
So they just won't clump.
Exactly. And rhinoplasty involves a surgeon intentionally cutting through some of the most highly vascularized, densely packed tissue in the entire human body.
Right, that nasal plexus we just talked about.
Yes, if the patient's platelets are greased and unable to aggregate, the surgical team is going to be fighting uncontrollable hemorrhage on the table. And the patient is going to suffer massive, potentially life-threatening postoperative bleeding into their airway.
Which points to something I find fascinating about modern clinical care. The medical procedure itself isn't the whole story.
Not even close.
The success of a highly technical surgery relies heavily on patient education. The postoperative care for rhinoplasty obviously focuses on maintaining the airway and managing pain, but the text makes a huge point to emphasize teaching the client to detect complications at home.
Because the surgeon isn't going to be sitting on the patient's couch on day 4 of recovery.
Exactly. The patient needs to understand the difference between normal postoperative oozing and a dangerous arterial bleed.
Patient teaching is arguably the most critical nursing intervention. The mechanical fix in the OR only holds if the patient understands the mechanics of their own recovery.
Let's pivot from trauma and structural fixes to infections and inflammation. The modules group the major upper airway inflammatory issues into allergic rhinitis, acute viral rhinitis, which is just the common cold influenza, and sinusitis.
And, I think most people lump these together as just having a stuffy nose.
Right. But the underlying mechanisms are wildly different.
The distinction is vital for treatment. Allergic rhinitis is an immune hypersensitivity. The body is reacting to a harmless environmental particle like pollen or pet dander, as if it were a deadly pathogen.
Whereas acute viral rhinitis, the common cold, is an actual viral invasion of the upper respiratory mucosa.
Right, and influenza is a much more aggressive, systemic viral infection that mutates seasonally.
And sinusitis is primarily a mechanical plumbing issue.
Yes, let's talk about the plumbing of sinusitis.
We have these hollow cavities in our skull, the sinuses, which produce mucus that drains into the nasal cavity. Sinusitis develops when the tiny exit doorways of those sinuses become narrowed and blocked by swelling.
Usually that swelling is secondary to a cold or an allergy. The exit gets blocked, but the sinus lining keeps producing mucus.
So the fluid is trapped in a dark, warm, moist cavern.
It is the absolute perfect breeding ground for bacteria. What starts as a viral swelling quickly turns into a secondary bacterial infection localized inside the skull bone, which creates immense pressure and facial pain.
Now, regarding allergic rhinitis, the clinical presentation described in the text is incredibly specific. Beyond the nasal congestion and sneezing, it describes the visual appearance of the inside of the nose.
Right.
If a clinician looks inside, the nasal turbinates appear pale, boggy, and swollen, which is contrasted with a thin, watery nasal discharge. That specific phrase, pale, boggy, and swollen, feels like a massive diagnostic clue.
It absolutely is.
Because if I have a viral cold, I expect the inside of my nose to look bright red and angry. Why does an allergy make it look pale and waterlogged?
To understand that, you have to look at the chemical cascade of an allergy. When a pollen grain lands on the nasal mucosa of someone with allergic rhinitis, It binds to specific antibodies,
Okay.
which trigger local immune cells called mast cells to literally explode, releasing massive amounts of histamine.
Histamine is the chemical that causes all the misery.
It really is. Histamine is a powerful vasodilator. It causes the local blood vessels to widen and their walls to become highly permeable, literally leaky.
So because the vessels are leaky, clear fluid from the bloodstream rushes out into the surrounding nasal tissue.
Yes, the tissue swells up like a sponge soaking up water. That is the boggy, swollen aspect.
So where does the pale part come from? If the blood vessels are wider, shouldn't it look more red?
It's a matter of tissue pressure.
Oh, really?
Yes. The tissue becomes so aggressively engorged with leaked fluid that the physical pressure of the waterlogged tissue actually compresses the tiny capillaries right on the surface of the mucosa.
Wow.
The blood is squeezed out of the superficial surface, giving it a pale, washed-out appearance compared to the bright red, highly arterialized inflammation of a viral infection, where immune cells are aggressively flooding the tissue to kill a virus.
That is fascinating. The fluid leaks out, causes massive swelling, and then the swelling itself acts like a pressure bandage from the inside, squeezing the surface blood away.
Pale and waterlogged for allergies, red and angry for viruses.
Well, having explored the upper perimeter, we need to travel downward. As miserable as upper respiratory issues are, the truly high-stakes, life-or-death emergencies happen when we travel down the trachea and into the lungs themselves.
Right into the lower respiratory tract.
We are entering what I like to call the plumber's nightmare. We are dealing with deflated structures and fluid leaking into all the wrong places.
The lower tract is where the actual business of gas exchange occurs. The upper tract just prepares the air. Any mechanical disruption down in the alveoli or the pleural space immediately threatens the oxygenation of the entire body.
And the modules highlight two massive concepts here that every clinical student must master: atelectasis and pleural effusion.
Let's start with atelectasis.
The text defines this as lung collapse, resulting from deflated alveoli, those millions of tiny grape-like air sacs just completely flatten out.
Right.
And it specifically notes this is incredibly common after surgery caused by mucus plugs. The symptoms are tachypnea, which is rapid breathing, a persistent cough, and a mild fever.
And the primary nursing prevention strategy is entirely mechanical. Early ambulation, deep breathing exercises, and chest physiotherapy.
But I want to push on the why here. Is atelectasis purely just a piece of mucus blocking a tube? Or is there a behavioral component because the patient just had surgery?
The behavioral component is actually the primary driver, which then leads to the physical mucus plug. It is a vicious, compounding cycle.
Walk me through it.
Well, during a major surgery under general anesthesia, the patient's lungs are not expanding fully. The ventilator does the work, but it often doesn't mimic the deep, varying size of natural breathing.
So the base of the lungs might not get fully aerated.
Right. Then the patient wakes up. If they had abdominal or thoracic surgery, they have a massive fresh incision slicing through muscle and fascia.
And moving those muscles hurts. Taking a deep breath stretches the incision.
Exactly. So the patient engages in a behavior called splinting. They take the shallowest, tiniest breath possible to avoid triggering the pain.
Because they are taking shallow breaths, fresh air never reaches the deepest, most peripheral alveoli.
And this is where the physics of the lungs comes in. Alveoli aren't rigid boxes. They're delicate balloons.
Right, and if you don't periodically force air into them to keep them popped open,
The natural surface tension inside the tiny sac will eventually cause the walls to stick together and collapse.
without the mechanical pressure of a deep breath, they just fold up.
Yes. And simultaneously, because the patient is in pain, they refuse to cough. The mucociliary escalator we talked about earlier is still sweeping normal daily mucus up the airways.
But without the explosive force of a cough to clear it, that mucus just sits in the lower airways.
And because the patient is usually slightly dehydrated post-op, that pooled mucus thickens and hardens into a physical plug.
So now, even if the patient eventually tried to take a deep breath, the air can't reach the collapsed alveoli because a concrete pillar of mucus is blocking the airway leading to them.
Which perfectly explains the logic behind the nursing interventions.
Early ambulation.
Exactly. Getting the patient out of bed and walking down the hall on the day of surgery forces their skeletal muscles to demand oxygen.
The brain's respiratory center overrides the pain response and forces the patient to take deeper breaths, naturally popping those alveoli back open.
And they often use a device called an incentive spirometer, where the patient has to suck air in to float a little plastic ball.
It gives them a visual goal to ensure they are creating enough negative pressure to pull air past any pooling mucus and inflate the bases of their lungs.
If you understand the mechanics of splinting and collapsing balloons, the preventative care makes perfect sense. You don't need a drug. You need mechanical force.
Now, atelectasis is a problem of deflated tissues. The other major lower respiratory issue is a problem of fluid displacement, pleural effusion.
A classic plumbing issue.
The text defines pleural effusion as fluid buildup in the pleural space, which causes dyspnea, shortness of breath, and severe chest pain. It's diagnosed and treated via a procedure called a thoracentesis, which involves sticking a needle through the chest wall to drain the fluid.
And the text notes this requires extreme caution.
Right. But the absolute goldmine in this section, what the source actually labels a high-yield exam pearl, is the diagnostic comparison between transudative and exudative pleural effusions.
If you are going to work in healthcare, you will encounter this distinction constantly. First, let's define the anatomy. The lungs are wrapped in a thin membrane called the visceral pleura. The inside of the rib cage is lined with a similar membrane called the parietal pleura. Between these two membranes is a microscopic gap called the pleural space.
And normally there's just a tiny slick of fluid there, acting as a lubricant so the lungs can slide against the ribs without friction when you breathe.
Right. A pleural effusion is when that microscopic gap fills with liters of excess fluid. Because the rib cage is rigid, the fluid has nowhere to go but inward, violently squishing and compressing the lung tissue until it can't expand.
But the vital clinical question is, why is the fluid there? And that is where we divide them into transudative and exudative. Looking at the table, it's entirely about understanding the mechanisms of systemic versus local pressure.
Let's take transudative effusions first.
The text says transudative effusions are caused by systemic pressure imbalances. Specifically, elevated hydrostatic pressure or decreased oncotic pressure.
Yes.
The fluid that gets drained out of the chest is clear, thin, and watery. It has very low protein levels, low LDH enzymes, and almost no white blood cells.
And it is caused by massive systemic diseases like congestive heart failure, severe liver cirrhosis, or nephrotic syndrome in the kidneys.
And the treatment focus isn't on the lung itself, it's treating the systemic disease, like giving diuretics to make the patient urinate out the excess fluid. I want to build a home repair analogy for this to explain those pressure imbalances.
I think an analogy is highly necessary here because hydrostatic and oncotic pressures are concepts that confuse a lot of people.
Let's imagine the capillary blood vessels in the pleura are the concrete walls of your basement. A transudative effusion is like water seeping into your basement because the groundwater table outside your house is just way too high.
Oh, I see.
There is absolutely nothing structurally wrong with your basement walls. They aren't cracked, the pipes aren't broken. But the systemic pressure of the groundwater outside is so incredibly intense that pure, clear water just gets forcefully squeezed right through the microscopic pores of the impact concrete. It's a pure pressure problem.
That maps perfectly to the physics of hydrostatic pressure. In congestive heart failure, the left side of the heart isn't pumping effectively, so blood backs up.
Right.
It backs up into the veins of the lungs and the pleura. This creates massive mechanical pressure pushing outward against the walls of the blood vessels. That is hydrostatic pressure.
It literally squeezes the water out of the blood.
Yes. The walls of the blood vessels are intact, the concrete is fine. Therefore, large molecules like heavy proteins and massive white blood cells cannot fit through the microscopic pores of the vessel wall.
Only the smallest molecule water can squeeze through.
That is exactly why transudative fluid is clear, watery, and low in protein.
What about decreased oncotic pressure? The text mentions liver cirrhosis causes this.
Oncotic pressure is the opposite force. Inside your blood, you have heavy proteins, primarily albumin, which is manufactured by the liver.
Okay.
These proteins act like molecular sponges. Their chemical properties exert a pulling force that holds water inside the blood vessel, preventing it from leaking out.
Got it.
Yeah.
And in liver cirrhosis, the liver dies and stops making albumin.
So you lose the sponges.
You lose the pulling force.
Exactly. Even with normal blood pressure, if there are no sponges holding the water in the vessels, the water just naturally seeps out into the tissues and the pleural space.
And again, the vessel wall is intact, so only clear water leaks out.
Yes.
And that elegantly explains the treatment. If your basement is flooding because the water table is too high, you don't just keep bailing out the basement with a bucket.
No, you have to lower the water table.
Right. In heart failure, you give the patient powerful diuretics. Their kidneys pull the fluid out of the blood and turn it into urine, the hydrostatic pressure drops, and the clear fluid in the chest gets reabsorbed naturally.
It's treating the root cause.
Okay, now let's contrast that pressure problem with an exudative effusion.
Exudative effusions operate on a completely different mechanical reality.
The sources indicate exudative effusions are caused by local inflammation, severe infection, or structural tissue damage directly inside the lung or pleura.
Yes, it's local.
The fluid that drains out is turbid, thick, cloudy, and sometimes bloody. It has high protein ratios, high LDH enzyme levels, and elevated white blood cells.
It's caused by local disasters, severe bacterial pneumonia, lung cancer tumors, or a pulmonary embolism.
And the treatment is to attack the local issue, directly giving IV antibiotics, inserting a permanent chest tube to drain the sludge, or administering chemotherapy. So back to my basement. Exudative is not the groundwater pressure.
Right.
Exudative is when a massive, angry rat physically chews a jagged hole right through the main sewage pipe inside your basement.
The structural integrity of the pipe is compromised.
Exactly. The wall itself is destroyed.
Mm.
So what floods your basement isn't clear groundwater squeezed through concrete. It's a torrent of thick, cloudy, debris-filled sludge pouring directly out of a broken pipe.
Biologically, that rat is severe inflammation. When lung tissue is attacked by a pneumonia bacteria or a cancerous tumor, the body mounts a massive inflammatory response.
Okay.
Inflammatory chemicals literally alter the structure of the local blood vessels. They cause the tight junctions between the cells of the vessel wall to pull apart, creating physical gaping holes in the capillaries.
The pipe is broken.
Because there are physical holes in the vessel wall, the fluid that leaks out isn't just water. Huge, heavy molecules pour out into the pleural space.
Huh.
Massive plasma proteins leak out.
Millions of white blood cells rushing to fight the infection pour out.
Exactly. And LDH lactate dehydrogenase, which is an enzyme found inside healthy cells, spills out in massive quantities because the local lung cells are actively dying and bursting open, dumping their contents into the fluid.
Which is why the fluid is turbid, thick, and packed with cellular debris. And just like the analogy, giving a patient with pneumonia a diuretic won't fix a chewed-up pipe. You have to kill the rat.
You have to give antibiotics to stop the localized inflammatory destruction. And you often have to physically stick a large bore chest tube into the space to aggressively suction out that toxic infected sludge before it creates permanent scar tissue around the lung. Understanding the difference between clear fluid squeezed by pressure and thick sludge leaking from structural damage is a fundamental paradigm of clinical diagnosis.
This brings us to a really intense transition in the source material, because fluid in the wrong place isn't just an anatomical curiosity or a chronic, slow-moving nuisance.
No, things can escalate fast.
The modules make a hard pivot into the urgent threats. We are talking about sudden, catastrophic, life-threatening emergencies where minutes matter. And the first one on the list sounds suspiciously similar to a pleural effusion, but mechanically, it is a fundamentally different crisis: pulmonary edema.
This is a crucial anatomical distinction. We just established that a pleural effusion is fluid around the lungs, trapped in that outer pleural envelope, squishing the lung tissue from the outside.
Right.
Pulmonary edema is fluid accumulating specifically inside the lung tissue, flooding the very alveoli where oxygen transfer is supposed to happen.
The text links pulmonary edema directly to acute left-sided heart failure. Let's think of the cardiovascular system as a massive highway system.
Okay.
The left side of the heart acts as the exit toll booth for blood leaving the lungs to get out to the rest of the body. If that left ventricle suddenly fails, maybe due to a massive heart attack, the toll booth shuts down.
But the right side of the heart is still pumping blood into the lungs.
The traffic backs up. It backs up all the way from the left atrium into the pulmonary veins and right back into the delicate microscopic capillary networks surrounding the alveoli.
The hydrostatic pressure we talked about earlier spikes so rapidly and so intensely that the thin walls of the capillaries essentially fail. Fluid is blasted out of the bloodstream directly into the air sacs.
So instead of the air sac filling with oxygen, it fills with blood plasma. The patient is literally mechanically drowning in their own fluid from the inside out.
It is a terrifying clinical presentation. The patient will be extremely agitated, gasping for air, and they often cough up a frothy, pink, blood-tinged sputum, which is the physical fluid bubbling up from their flooded alveoli.
That's awful. And oxygen therapy alone cannot fix this, right?
Mm-hmm.
Because the oxygen cannot physically swim through the fluid to reach the blood.
Exactly. The emergency intervention requires massive, rapid doses of intravenous diuretics to instantly pull the fluid volume out of the blood, and powerful vasodilator drugs to expand the blood vessels and take the pressure off the failing heart toll booth.
Right next to pulmonary edema in the urgent threat category is another mechanical catastrophe, pulmonary embolism, or PE.
Also extremely dangerous.
The text defines this as a physical blockage of the pulmonary arteries by a thrombus, which is a blood clot.
Hmm.
The listed risk factors are prolonged immobilization, deep vein thrombosis, and recent surgery.
Because if blood sits still, like when you are bedridden, it tends to coagulate.
The symptoms hit like a freight train. Sudden, unexplained dyspnea, sharp, stabbing pleuritic chest pain that worsens when you inhale, and severe tachycardia.
A PE is a pure mechanical obstruction of the plumbing. A massive clot usually forms deep in the large veins of the legs or pelvis.
Okay.
The danger occurs when a piece of that clot breaks off. It travels through the ever-widening veins back to the right side of the heart. The right ventricle then pumps that solid clot into the pulmonary artery, which branches into smaller and smaller vessels inside the lung.
So it's traveling until it can't fit anymore.
Eventually, the clot reaches a vessel that is smaller than itself, and it slams into it like a cork in a wine bottle.
And the lights go out for that section of the lung.
Instantaneously.
Yeah.
The lung tissue beyond that clot is suddenly cut off from its blood supply, leading to rapid tissue death.
But more importantly for the whole body, a massive segment of the lung is suddenly useless for gas exchange.
Yes, you can breathe all the air you want into those alveoli, but because the blood flow is blocked by the cork, the oxygen has no blood to enter.
The diagnosis for a PE involves a CT angiogram, where they inject contrast dye to physically see the blockage on a scan.
Yeah.
But it also mentions a specific blood test, the D-dimer test.
The D-dimer is a very clever test.
I really want to understand the mechanics of this test. How does the blood test tell you there's a cork in the lung?
A D-dimer test doesn't actually look for the clot itself. It looks for the debris left behind when the body tries to fight the clot.
Oh, really?
Yeah. When a blood clot forms, it's held together by a tough protein called fibrin. Almost immediately after a clot forms anywhere in the body, your internal biological cleanup crew, an enzyme called plasmin, starts trying to hack away at it and dissolve it.
Okay.
When plasmin chops up the fibrin, it leaves behind very specific protein fragments in the bloodstream. Those fragments are called D-dimers.
It's like finding a massive pile of sawdust. The sawdust doesn't tell you exactly which room the carpenter is working in, but it absolutely proves that someone is actively sawing wood nearby.
A perfect analogy. If a patient comes into the ER with sudden sharp chest pain and shortness of breath, and their D-dimer test comes back highly elevated, it tells the medical team that the body is actively, aggressively trying to dissolve a massive clot somewhere.
Which, combined with the symptoms, points a giant flashing arrow at a pulmonary embolism.
Demanding immediate intervention with anticoagulants like heparin to prevent the clot from growing, or powerful thrombolytic drugs designed to artificially dissolve the blockage before the patient's cardiovascular system collapses against the back pressure.
This leads me to a really challenging diagnostic question. The third urgent threat in this section is lung cancer.
Right.
The text correctly identifies smoking as the primary overwhelming risk factor.
Yeah.
But it notes that the early symptoms of lung cancer are incredibly non-specific things, like a persistent nagging cough.
Very easy to brush off.
Exactly. As the tumor advances, symptoms escalate to weight loss, severe chest pain, and breathlessness. So here's my question. If lung cancer presents with chest pain and breathlessness, and a pulmonary embolism presents with chest pain and shortness of breath, and even a severe asthma attack causes breathlessness, how does a clinician differentiate these presentations on the spot? They all sound like the same thing to a layperson.
It entirely comes down to the timeline of the mechanism. The mechanism dictates the speed of the symptom onset.
So speed is the key.
Yes. A pulmonary embolism is the definition of acute mechanical failure. A patient could be sitting comfortably, stand up to walk to the bathroom, and within 10 seconds, they're clutching their chest, turning blue, and gasping for air.
The onset is instantaneous because the cork slammed in the vessel instantly.
Right.
And lung cancer is the exact opposite timeline.
Lung cancer is a slow, insidious anatomical siege. A tumor takes months or years to grow. The persistent cough has likely been there for half a year, slowly worsening.
And the breathlessness wasn't sudden. It has been a gradual realization over months that they can no longer climb a flight of stairs without stopping.
Precisely. The chest pain in lung cancer is typically a dull, persistent ache caused by a massive tumor physically invading and compressing the nerves of the chest wall.
And it's almost always accompanied by systemic signs of cancer, like profound, unexplained weight loss and muscle wasting, as the tumor steals the body's nutrients.
It's the difference between an earthquake and a slow-moving glacier. They both destroy the landscape. but the speed of destruction gives away the cause.
Now, you mentioned asthma earlier, which perfectly transitions us into the next major concept in the modules, the chronic obstructive battle. Because while a PE is a sudden crisis, millions of people are fighting slow-burning chronic wars in their airways every single day.
We are looking at asthma versus COPD.
And the text makes it incredibly clear that there is one major high-yield clinical dividing line between these two diagnoses.
If there is one concept to take away regarding chronic airway disease, it is the concept of reversibility. Asthma is fundamentally a reversible airflow obstruction.
Reversible being the key word.
Yes, COPD, chronic obstructive pulmonary disease, is a progressive and irreversible airflow limitation.
Let's deeply unpack asthma first. The pathophysiology outlines that the airways of an asthmatic are hypersensitive to environmental triggers.
These triggers could be anything: pet dander allergens, cold air, heavy exercise, emotional stress, or even respiratory viruses.
When the airway is exposed to a trigger, a massive overreaction occurs. The smooth muscles wrapping around the bronchi instantly contract in a violent spasm.
Simultaneously, the internal lining of the airway becomes intensely inflamed and swollen, and the local glands go into overdrive, producing excess thick mucus.
So you have three distinct mechanical forces working to narrow the pipe. The muscle is strangling it from the outside, the walls are swelling inward, and the remaining hollow space is filling with mucus.
The resistance to airflow skyrockets. The patient has to force air through a pinhole, which creates the high-pitched whistling sound we know as wheezing.
They experience terrifying chest tightness and coughing, which the text notes often worsens at night or in the early morning due to natural circadian drops in the body's anti-inflammatory hormones.
But the key is that word, reversible, because the underlying architecture of the lung hasn't been destroyed.
The management involves two main pharmacologic strategies. During an attack, they use short-acting bronchodilators, like an albuterol inhaler.
Right. These drugs bind directly to receptors on those smooth muscles and force them to relax, physically opening the pipe back up within minutes.
And for long-term control, they use inhaled corticosteroids, which locally suppress the immune system in the lungs.
Calming down that hypersensitive inflammatory baseline so the airways stop overreacting to every minor trigger. If an asthmatic removes the triggers and uses their medication, their airways can return to a completely normal, wide-open state.
I picture asthma like a reversible traffic jam. A truck spills its cargo on a major highway. That's the asthma trigger. The lanes get blocked, traffic backs up for miles, everyone is honking and stressed. That's the wheezing, the coughing, the acute attack.
But eventually, the tow trucks arrive.
Exactly. The bronchodilators clear the debris and open the lanes. The highway itself is fine. Traffic flows freely again at 70 miles an hour.
That is a highly accurate representation of asthma. Now contrast that with COPD.
COPD is the irreversible trap. The text identifies cigarette smoking as the primary, overwhelming risk factor, accounting for the vast majority of cases, along with severe air pollution, genetics, and the aging process.
And COPD is actually an umbrella term. When a patient has COPD, they usually have a combination of two distinct coexisting conditions.
Chronic bronchitis and emphysema. Both destroy the lungs, but they do it in completely different ways.
Let's break down the mechanics of chronic bronchitis first. We talked about the mucociliary escalator earlier.
In a smoker, the airways are subjected to the constant daily inhalation of highly toxic burning chemical smoke. This is extreme, chronic irritation.
In response, the body tries to protect itself. The goblet cells, the cellular factories that produce mucus, actually multiply and grow larger in an attempt to coat the lungs in protective slime to shield against the smoke.
It's a defense mechanism that ends up killing you.
Exactly. The airway lining becomes permanently, constantly inflamed. Over years and decades of this chronic inflammation, the delicate tissue of the airway walls physically thickens and scars.
You now have narrowed, scarred pipes that are constantly overflowing with thick, tenacious mucus, and the toxic smoke has simultaneously paralyzed and destroyed the cilia, so the escalator is broken.
The patient develops a chronic, wet hacking cough, just trying to clear the massive daily volume of mucus.
Returning to my highway traffic analogy, asthma was the temporary spill that got cleaned up. Chronic bronchitis is like the highway itself crumbling into dirt and being permanently covered in wet, hardening cement.
Yes. You can't just clear the traffic jam because the physical infrastructure of the road is fundamentally narrowed, scarred, and destroyed.
That paints a grim picture, but it perfectly explains the irreversibility. But COPD also involves emphysema, which attacks the architecture even deeper in the lungs.
The alveoli.
Yes. The toxic chemicals in cigarette smoke trigger the local immune cells to release highly destructive enzymes called proteases.
Normally, the lung has defenses against these enzymes, but the sheer volume of smoke overwhelms the defenses.
These proteases literally digest and destroy the elastin proteins that make up the walls of the alveoli.
The text describes the alveoli losing their distinct grape-like structure and fusing together into large, shapeless, floppy entities like deflated balloons.
Okay, I really want to dig into the physics here, because this is a paradox that confused me for a long time.
Okay.
I can easily visualize a floppy, deflated balloon. But how does a deflated balloon cause the classic hallmark symptom of advanced COPD? You always hear about COPD patients suffering from severe air trapping and developing a massive barrel-shaped chest over time.
Right.
If the balloons are deflated and floppy, how on earth does air get permanently trapped inside them?
That is a phenomenal question, and it requires understanding the physics of exhalation. Remember the heavy, self-closing security door analogy we use for elastic recoil?
Yeah.
Healthy alveoli act like tight, brand-new rubber balloons. When you inhale, your strong diaphragm muscle contracts, pulling the lungs open, air rushes in, and the rubber walls of the alveoli stretch tightly.
Okay.
When you want to exhale, you just relax your diaphragm. The tight rubber walls naturally snap back to their original size, and that elastic force forcefully squeezes the stale air back out of the lungs.
Inhaling is active muscle work. Exhaling is just letting go of the stretched rubber band.
Exactly. But in emphysema, the smoke has dissolved the rubber band, the elastin is gone. The alveoli are now large, floppy, plastic grocery bags.
Oh.
When the COPD patient breathes in, their strong diaphragm can still pull air into these floppy bags, but when they relax to exhale, there is no elastic snap. The bags just sit there full of stale air.
So they have to start using their chest and abdominal muscles to actively squeeze the lungs to force the air out.
And that muscular squeezing creates the fatal trap. The tiny airways, the bronchioles that lead out of the alveoli rely on the tension of the surrounding elastic lung tissue to tether them open, like guy wires holding up a tent.
In emphysema, those guy wires are destroyed.
Yes. When the patient forcefully squeezes their chest muscles to push the air out, the massive internal pressure collapses those unsupported floppy bronchioles shut. The exit door literally slams shut before the air can escape.
Oh, wow. So the harder they try to push the air out, the tighter the exit door squeezes shut.
It's called dynamic hyperinflation. The air is mechanically trapped. Breath after breath, month after month, year after year, more and more stale air gets trapped in these destroyed, floppy spaces.
The lungs become massively overinflated. They expand so much that they literally push the ribs outward, remodeling the entire skeleton into that classic barrel chest shape.
And because the lungs are permanently full of trapped, stale, carbon dioxide-rich air, there is no physical room to breathe in fresh, oxygen-rich air. The patient is slowly suffocating while their lungs are completely full.
This is exactly why the clinical management for severe COPD shifts dramatically away from expecting a cure. You cannot undestroy the elastin. You cannot rebuild the alveoli.
The care shifts to symptom relief, targeted oxygen therapy, and intensive pulmonary rehabilitation to teach the patient special breathing techniques.
Like pursed lip breathing, which creates back pressure to hold the floppy airways open just a little bit longer during exhalation.
It underscores the absolute terrifying urgency of smoking cessation. By the time a patient feels the breathlessness of emphysema, the structural architecture of their lungs has already crumbled. The only intervention is to stop the destruction before the remaining healthy tissue is digested.
Well, after exploring these chronic diseases that primarily affect adults and the aging population, the Sheridan modules make a critical pivot. Respiratory distress is not just a problem caused by decades of wear and tear or terrible habits.
Some of the most severe, devastating respiratory challenges begin in the very first days and months of life. We're talking about pediatric respiratory vulnerabilities.
The clinical shift here is massive. An infant or child's respiratory system is not just a miniature adult system, it is actively developing.
The physical diameter of a pediatric airway is microscopic, which means even a single millimeter of inflammatory swelling that an adult wouldn't even notice can completely obliterate an infant's airway.
Furthermore, their immune systems are naive. They are encountering massive viral threats for the very first time without any acquired antibodies.
The sources focus on three major pediatric threats: cystic fibrosis, RSV, and SADs.
Let's start with cystic fibrosis, or CF. The pathophysiology outlined here traces it down to a single genetic mutation, specifically the CFTR gene.
This gene mutation breaks the mechanism that transports chloride and sodium ions across cell membranes.
Because this molecular transport is broken, the body produces incredibly thick, sticky, concrete-like mucus. The clinical manifestations for the lungs are severe. A persistent, hacking cough with viscous, purulent, greenish sputum, recurrent, life-threatening bacterial infections because the mucociliary escalator can't move the concrete.
An eventual progressive respiratory failure. But the text also lists symptoms that happen entirely outside the lungs. Failure to thrive, digital clubbing in the fingers, massive, frequent, foul-smelling bowel movements, and a protuberant, bloated abdomen paired with severely emaciated arms and legs.
To a layperson, that symptom list sounds like three completely different diseases. How does a genetic defect that causes thick mucus in the lungs translate into a starving child with massive bowel movements?
The connection isn't immediately obvious at all. I want to try and trace the biology here, step by step. Tell me if I have this right. The CFTR gene provides the blueprint for a microscopic channel on the surface of cells, a channel that pumps chloride ions out of the cell.
In CF, that channel is broken or missing,
Mhm.
so chloride is trapped inside. And because of the laws of osmosis, sodium usually follows chloride, and water always follows salt.
That is exactly the osmotic principle at work. In a healthy person, the cell pumps salt out onto the surface of the airway and water flows out of the cell to dilute the salt, creating a thin, watery layer of mucus.
In CS, the salt can't get out, so the water stays trapped inside the cell. The mucus on the surface becomes completely dehydrated, turning into a thick, sticky paste.
Okay, so that explains the lungs. But the CFTR gene isn't just in the lungs, it's in the exocrine glands throughout the entire body, including the pancreas.
The pancreas is the organ that produces digestive enzymes like lipases to break down fat and amylases to break down carbs. Those enzymes are supposed to flow through tiny pancreatic ducts into the intestines to digest food.
In a child with CF, that same defective chloride water transport creates concrete-like mucus inside the pancreas, completely blocking the tiny exit ducts. The digestive enzymes can never reach the food in the intestines.
The mechanical blockage is total. The child could be eating constantly, ravenously consuming thousands of calories, but they are literally starving to death because they cannot chemically absorb a single nutrient.
The food passes right through their digestive tract, completely unprocessed.
Yes, that is what causes the large, frequent, fatty, and incredibly foul-smelling bowel movements. Because the body is starving, it starts consuming its own fat stores and muscle tissue just to keep the brain and heart alive, which leads to the emaciated extremities.
Meanwhile, the undigested food and trapped gas in the gut cause the abdomen to become bloated and protuberant. This is why CF management isn't just about airway clearance vests and inhaled antibiotics for the lungs. It fundamentally requires aggressive nutritional support.
Patients have to take high-dose synthetic pancreatic enzyme pills with every single meal and snack for the rest of their lives, just to digest their food.
It is a full system war caused by a broken salt pump. And they diagnose it with the sweat chloride test, right? Because that broken sodium chloride transport also malfunctions in the sweat glands, causing their sweat to be unusually measurably salty.
Which is often first noticed when a parent kisses their baby's forehead. They combine that with genetic testing to confirm the exact CFTR mutation. Now, I want to clarify one more symptom on that list. Digital clubbing, the enlargement and rounding of the fingertips. How does lung mucus change the shape of your fingers?
Clubbing is a fascinating physiological response to chronic hypoxia. When the lungs are constantly failing to deliver enough oxygen over a period of years, the body senses that the peripheral tissues, like the fingertips, are chronically starving for oxygen.
In a desperate attempt to fix this, the body releases massive amounts of a chemical called vascular endothelial growth factor, or VEGF. This chemical signals the blood vessels in the fingertips to hyperproliferate, growing new capillary beds to try and capture more oxygen.
This massive overgrowth of tiny blood vessels physically bulges the tissue of the fingertips outward, creating that rounded, club-like appearance.
It's the body trying to build more roads to a starving town. Moving from a genetic threat to an infectious one, the modules cover RSV, respiratory syncytial virus. This is a viral infection that surges from fall to spring, and it predominantly affects infants and toddlers.
It causes a condition called bronchiolitis, which is the severe inflammation and swelling of the absolute tiniest airways in the lungs, the bronchioles. The progression described here is terrifying for a parent to watch.
It starts exactly like a benign, simple cold, a runny nose and a low-grade fever. But over a few days, it progresses downward into the lungs, causing a severe paroxysmal cough, intense wheezing, hypoxia, and tachypnea, with the infant breathing over 70 times a minute.
Eventually, the infant becomes so exhausted they exhibit an inability to suck a bottle and breathe simultaneously.
We have to return to the physics of airway diameter to understand why this is so dangerous. In physics, there's a principle called Poiseuille's law, which dictates that resistance to airflow increases exponentially as the radius of a tube decreases.
If an adult's airway swells by 1 millimeter, it's a minor annoyance. If an infant's bronchiole, which might only be 2 millimeters wide to begin with, swells by 1 millimeter, the resistance to airflow doesn't just double, it increases by a factor of 16.
So the infant has to exert 16 times the muscular effort just to pull a single breath of air through that swollen, mucus-filled microscopic tube.
They are essentially running a marathon while lying flat in their crib. An infant breathing 70 times a minute is rapidly burning through their entire energy reserve. They become too exhausted to eat or drink.
This leads to rapid dehydration, which makes the mucus in their lungs even thicker and stickier, further increasing the airway resistance. It is a terrifying downward spiral. The medical treatment is largely supportive. We cannot cure the virus.
We provide supplemental oxygen, intravenous hydration to keep the mucus thin, and humidified air, basically acting as life support to give the infant's own immune system the time and energy to fight off the viral invasion.
But the detail in the text had absolutely stunned me. The piece of information that makes this virus so pervasive is the transmission data. It spreads airborne via droplets by direct contact, but also by indirect contact on inanimate objects. The text explicitly states that the RSV virus can survive for half an hour on a person's hands and up to 5 solid hours on countertops and surfaces. 5 hours.
That means a sick toddler could sneeze on a plastic toy block at a daycare center at 8 a.m., go home sick, and another perfectly healthy infant could pick up that exact same block after lunch, rub their eye, and contract a life-threatening respiratory infection.
RSV is remarkably, almost uniquely resilient on fomites, which is the clinical term for contaminated inanimate surfaces. Many respiratory viruses, like the flu, degrade very quickly once they dry out on a surface. RSV's viral envelope is incredibly tough.
This specific characteristic is why nursing interventions and public health guidelines focus so heavily on contact isolation and aggressive, strict hand washing. When you wash your hands or sanitize a toy, you aren't just protecting a single patient. You are trying to break the chain of a highly durable pathogen that has the capability to wipe out an entire pediatric ward or shut down a daycare center.
Which brings us to the final and undoubtedly the most heartbreaking pediatric vulnerability covered in these texts: SIDs, or sudden infant death syndrome. The definition provided is incredibly strict. It is the sudden, unexplained death of a seemingly healthy infant, occurring predominantly between 1 and 4 months of age.
The critical word in that definition is unexplained. SIDs is a diagnosis of exclusion. The medical texts specify that a diagnosis of SIDs can only be confirmed retroactively after the tragic event has occurred through a comprehensive, exhaustive autopsy, a detailed examination of the death scene, and a thorough review of the infant's clinical history.
If the pathologist finds a clear cause like an underlying congenital heart defect, a severe undetected brain infection, or accidental mechanical suffocation from a blanket, it is clinically classified as that specific cause. It is not SIDS. SIDS is the diagnosis given when the autopsy is perfect, the scene is clear, and all the answers come back completely negative.
Which leaves parents and caregivers grappling with a terrifying, agonizing lack of control. Because it is a retroactive diagnosis of exclusion, there is no blood test you can run beforehand to see if your child has it. But the text does give us something vital to hold on to: the modifiable risk factors and the proven prevention strategies. I want to emphasize these deeply because this is urgently relevant to any listener who is a parent, grandparent, or anyone who might ever put a baby to sleep. The listed environmental risks are unsafe sleep positions, soft bedding, overheating, and exposure to tobacco smoke.
While we may not know the exact cellular trigger for SIDs, the epidemiological data is overwhelming. The public health campaigns surrounding these specific, modifiable preventative measures have saved tens of thousands of infant lives over the last few decades. The nursing teaching must drill this into every caregiver. The supine sleep position is non-negotiable. This means placing the baby completely flat on their back to sleep every single time, for naps and at night.
And the sleep surface itself matters just as much.
A firm, flat sleep surface, like a safety-approved crib mattress covered only by a fitted sheet. Absolutely no pillows, no loose blankets, no stuffed animals, and no crib bumper pads in the sleep area. Caregivers must avoid co-sleeping in an adult bed, as adult mattresses and bedding pose a massive suffocation risk. keeping the infant's room comfortably cool to prevent overheating, maintaining a strictly smoke-free environment during pregnancy and after birth, and promoting breastfeeding, which has been statistically shown to offer a protective effect, likely through enhanced immune support and improved arousability.
You mentioned arousability. I know we don't fully understand the exact mechanism of SIDs, but the leading neurological theory revolves around the brainstem, doesn't it? A potential delay or microscopic abnormality in the brainstem's arousal center. The theory is that if a healthy infant accidentally gets their face slightly covered or rebreathes some exhaled carbon dioxide, their brain instantly senses the rising CO2 and triggers a violent arousal reflex. They wake up, thrash around, and move their head to get fresh air. But in a SID's victim, that specific serotonin-driven arousal reflex might be fundamentally delayed or blunted. They don't wake up when the oxygen drops.
That is the triple risk model of SIs. It proposes that SIs occurs when three factors intersect. A vulnerable infant, with that microscopic brainstem abnormality, a critical developmental period in the first few months of life when their neurological systems are rapidly rewiring, and an exogenous stressor like sleeping face down on a soft mattress where they rebreathe stale air. We cannot yet test for or fix the brainstem vulnerability. Therefore, our only intervention is to completely eliminate the exogenous stressors. By manipulating the environment with those strict, safe sleep practices, we create a massive protective buffer that prevents the infant's fragile respiratory drive from ever being challenged in the first place.
It is about minimizing every conceivable external respiratory, thermal, or autonomic stressor on a developing infant's nervous system. We have covered an incredible, intense amount of ground today. I am taking a deep breath right now, both literally and figuratively, acknowledging just how heavy, intricate, delicate, and sometimes frightening the nature of our respiratory machinery really is.
The sheer complexity of human respiration is staggering. But hopefully, by walking through it with this level of mechanical detail, it feels less like a random, overwhelming list of terrifying diseases and more like a logical, understandable map of a very specific machine.
That is the goal. To summarize this deep dive for you, the listener, we've traveled from the rusty, stiffening hinges of aging lungs to the complex vascular beds of a bleeding nasal septum. We've waded through the fluid-filled battlegrounds of pleural effusions, figuring out if the basement flooded due to a high hydrostatic water table or a rat chewing through the pipes with inflammation. We've navigated the sudden, reversible traffic jams of asthma and stared down the crumbling, hyperinflated, irreversible highways of COPD. And we've faced the microscopic, 5-hour surviving viral threats of RSV, the tragic unknowns of SIDs, and the devastating genetic mutations of CF that starve an infant by breaking a simple cellular salt pump.
My final thought for you. Whether you are a nursing student staring down a massive clinical exam or just a curious learner trying to understand your own biology, is to always anchor yourself in the mechanics. Do not just memorize a list of symptoms. If you understand exactly how a structure is supposed to function in perfect health, how the cilia beat in unison, how the elastin snaps back to force air out, how the pressure gradients hold fluid perfectly balanced inside the capillary walls, you will always be able to logically deduce why it fails and exactly what intervention is needed to fix it.
As we wrap up, I want to leave you, our listener, with one final provocative thought to mull over, building on what we discussed with cystic fibrosis. We spent a lot of time talking about how CF is caused by a genetic failure of the CFTR gene to transport chloride and sodium across the cell membrane, resulting in that deadly concrete-like mucus blocking the lungs and the pancreas. Currently, the bleeding edge of medical research is focused entirely on biology, trying to genetically edit that broken DNA using CRISPR, or using highly complex, expensive modulator drugs to try and force the misfolded, broken protein channels to open. But what if the future of respiratory medicine isn't biological at all? What if it's entirely mechanical? What if the solution is nanotechnology? Imagine a future where we develop microscopic artificial ion channels, literal tiny molecular machines built in a lab. You simply inhale them through a standard inhaler. These nanobots would embed themselves directly into the lining of your lungs, completely ignoring your defective human genetics. They wouldn't try to fix the broken CFTR gene. They would just manually, artificially act as pumps, shuttling sodium and chloride across the cell membranes themselves. Could we artificially cure the mucus buildup, restoring perfect hydration to the lungs and pancreas without ever needing to touch or repair human DNA? The intersection of nursing care, human biology, and the frontier of future technology is wide open. Thank you so much for joining us on this intense mechanical plunge into the machinery that keeps us alive. Until next time, keep breathing easy.